This is the International Academy for Clinical Hematology. Welcome, everyone, and Happy New Year. I hope this new year, 2025, brings you all good health, success, and plenty of exciting opportunities. Let's make this year one of learning, growth, and collaboration. And thank you for joining this ICH webinar on the most exciting and impactful updates from the ASH 2024 annual meeting that was held in the beautiful city of San Diego. And today's focus is multiple myeloma. And this year's meeting showcased a wealth of groundbreaking research, innovative therapies, and fresh perspectives that are shaping the future of myeloma management. So over the next 45 minutes, I'll be sharing some key findings and discussing their clinical implications. That said, with such a vast amount of high-quality work presented at ASH, I had to make a selection to fit the time we have today. And while I have aimed to cover the most relevant and impactful studies, I may have inadvertently left out some important contributions. So for this, I do sincerely apologize in advance and encourage you to explore the full Congress proceedings to capture the broader picture. And of course, we will have a Q&A if we have some time at the end after my talk. So again, thank you for joining this ICH webinar dedicated to the key highlights from the ASH Congress. My name is Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. These are my disclosures, and this year, one of the biggest highlights was smoldering multiple myeloma. And this is about the release and subsequent publication of this phase 3 randomized study comparing daratumumab monotherapy versus active monitoring in patients with high-risk smoldering myeloma. And these are the primary results of this so-called AQUILA study. You can see here the design of this study. Of course, it has been designed several years ago, so the issues, there may be some subtle issues compared to our current understanding of smoldering multiple myeloma. Nevertheless, I think this is really a big and key achievement, and the investigators and all stakeholders who worked on this study should be really commended and congratulated for running such a difficult trial, comparing daratumumab anti-CD38 monoclonal antibody versus control arm with active monitoring and no disease-specific treatment, and of course, monitoring of adverse events. And the primary endpoint was about progression-free survival by the IRC using the SLIM, but also the CRAB criteria. And you can see here the summary of these criteria. And obviously, I'm showing this because today we may have run the trial differently. These are the characteristics. Obviously, they are balanced. It's a phase 3 randomized multi-center international trial. You would see that the median time from diagnosis to smoldering myeloma randomization was a little bit less than a year, 0.8, 0.67. the characteristics, according to the Mayo 2018 risk criteria, you can appreciate majority were in the intermediate and high risk. When you look into the treatment disposition, actually, and this is an important piece of information, at least 2/3 of the patients, 66%, completed the treatment with daratumumab. And obviously, there was a low rate of daratumumab discontinuation due to adverse events, suggesting that this active treatment is well tolerated. And obviously, the disease progression was lower in the daratumumab arm. And a lot of these patients are currently in follow-up, and the death rate was around 10%. This is the primary endpoint, and we have a relatively decent median follow-up, more than 5 years, showing that the median PFS with daratumumab was not reached, 63% at 5 years versus 41% median, 41.5 months in the active arm, and we have a hazard ratio of 0.49, so roughly 50% improvement, 51% when using dara monotherapy versus active observation. And these are the overall survival data, and again, there is a clear benefit here for using an early intervention. Safety, I think, of course, daratumumab now is well known since more than a decade. So the safety profile is in line with what we knew, but definitely there was a low rate of discontinuation due to side effects. And if you focus on AEs of special interest, especially, of course, when you're giving daratumumab long-term, you would think about infections. Actually, there were a few grade 3 and 4 infections, but the majority are recovered and resolved. No signal for second primary malignancies. And of course, this is the conclusion of the authors in favor of this early intervention with daratumumab monotherapy in patient with high-risk smoldering multiple myeloma. This was one of the most highly debated studies during ASH, but also after ASH. If there's going to be practice changing, I think the impact on overall survival is something we need to consider. There are always, in any kind of such trials, some weaknesses, and the perfect trial doesn't exist in my opinion, and I think everybody would agree on this, but this is really a great step forward with this story of high-risk smoldering multiple myeloma. We'll move now to the next section about treatment of transplant-eligible patient. And one of the highlights was this presentation from our colleagues from the German multiple myeloma group, and that was presented by Dr. Elias May. You may remember this trial already published once using isatuximab, anti-CD38 monoclonal antibody, and VRD, lenalidomide, bortezomib, dexamethasone for induction in transplant-eligible patient. This is the design of the trial, ESA-VRD versus VRD, high-dose melphalan transplant, and in some patient, there was a tandem transplant. The part 2 is another randomization looking into isatuximab, lenalidomide as a new option for maintenance compared to standard of care lenalidomide. And this presentation at ASH 2024 focused on the PFS from the first randomization comparing ESA-VRD versus VRD. So really the focus is the induction. Again, these were published, the baseline characteristics, nothing special. This is a transplant-eligible population, very well balanced. And as previously reported, there was a clear benefit for adding isatuximab to VRD. If you look in terms of MRD negativity at the end of induction therapy, so just by induction, you are bringing 50% of the patient into MRD negativity by 10 minus 5. So this is really something we already know this, for instance, from the Perseus trial with daratumumab VRD, but I think this is really an important confirmation. And of course, if you consider MRD negativity in those patients in CR or in those patients with more than VGPR in the intention to treat population, these numbers are even more elegant and further confirming the beneficial effect of adding isatuximab. Looking into PFS from first randomization, there's a clear separation between the curves in favor of the quadruplet, highlighting that after 4 years of median follow-up, definitely an 18-week course of ESA-VRD induction without consolidation. This is the importance here. We have just by the induction regimen, 30% reduction in the risk of progression compared to the popular VRD. The transplant-eligible population was also well served, I would say, during ASH. And as I just summarized the German study, there's another multi-center German study presented by Dr. Mark Raab. This is the so-called also Majestic 5. So the quadruplet regimen anti-CD38 plus VRD are now well established for induction. But here in this Majestic 5 phase 2 study, the authors attempted to incorporate a bispecific antibody, an anti-BCMA bispecific antibody, namely Teclistamab, during induction in those patients eligible to transplant. This is a study design. This is a 6-cycle induction, so classical, where they have used arm B Teclistamab every 4 weeks plus daratumumab, bortezomib, lenalidomide, arm A1 Teclistamab plus daratumumab, lenalidomide every 4 weeks, and arm A Teclistamab plus daratumumab, lenalidomide weekly. Of course, it's not randomized. The numbers are relatively small, 10, 20, 19 patient. And there is a subtle issue I wanted to highlight here about the dosage of Teclistamab. In the weekly dosage, that is the standard of care, the approved dosage, 1.5 milligram per kg in the relapse refractory setting. But in the monthly approach, in the monthly arms, be careful, this is 3 milligram per kg, and the devil is always in the details. Good news when it comes to side effects, especially opportunistic infections. So you can read this as the glass is half full or half empty, because we still have 35% of grade 3-4 infections. They are frontline patients. They are less advanced. We're talking about induction. But again, COVID-19 created some mess there. And the good news, there were no grade 5, no deaths, and no discontinuation due to infection. In terms of efficacy, it is quite impressive, quite amazing, because actually 100% of those evaluable patients are going to achieve MRD negativity by the 3rd cycle, which is quite incredible. Remember, with the quadruplet induction, we were talking about 50% MRD negativity after 6 cycles. Here we're talking already after 3 cycles. So the synergy joining forces between anti-CD38 and an anti-BCMA is likely something that we need to watch carefully. And I'm sure these bispecific antibodies will move progressively into earlier lines, whether in the transplant setting, but also in the non-transplant setting. And this is also being discussed. So really a very impressive perspective. Another perspective when it comes to the transplant-eligible population is the use actually of an anti-BCMA bispecific antibody like Teclistamab with or without lenalidomide for maintenance in the transplant setting. And this is here about the MajesTEC-4 trial, or the European Myeloma Network 30 trial presented by Dr. Elena Zamani. So you can see here, actually, these are newly diagnosed patients who went into 3 or 4 drug induction, but were randomized at time of maintenance into Teclistamab, lenalidomide, into Teclistamab or lenalidomide. And the goal is 1,500 patients. And it's a dual primary endpoint, progression-free survival, but also MRD negativity in those CR patients at 12 months. And of course, we are in the safety run-in phase to test the feasibility. And again, I would like to draw your attention that first we're talking here about a 2-year fixed duration maintenance regimen, which I think is an extremely important issue for the patient, because more and more I think we should aim for the fixed duration. Also, in cohort 2 and cohort 3, the dosage of Teclistamab was 3 milligrams per kg every month compared to cohort 1, which was more classical. Safety, well, as you would envision, it's a family effect, I would say. Hypogammaglobulinemia is problematic. And similar to when using Teclistamab in the induction setting, it looks like we are a bit stuck with this 25 to 30% of grade 3 and 4 infection. So it looks like there is a plateau, and I don't believe here COVID-19 was the responsible alone. Of course, IG replacement, infection prophylaxis was recommended strongly, and I hope that more and more people will be very stringent and will apply these prophylaxis, and this incidence of severe infections will decrease. In terms of efficacy, again, similar to the induction setting, if you consider the maintenance setting, actually 100% of the patient are going to become MRD negative. And of course, if you believe in the power of MRD negativity as a surrogate for cure, obviously we are on the right track. So you can see the field in the transplant setting is now moving towards incorporating bispecific antibodies as part of the induction, as part of the maintenance, and at some point, my best guess, and trials are ongoing, because of such a high rate of MRD negativity, we may be able to skip or postpone the use of high-dose melphalan. The progress and changes are not limited to the transplant-eligible population. In the older population or transplant-ineligible, one major study, a true highlight that has been praised by all investigators all over the place in social media, the study presented by Dr. Salomon Manier on behalf of our group, the IFM, and it's a very simple study. It's a dexamethasone-sparing regimen. You can see the design of the study. These are non-transplant eligible patients. They are frail patients, newly diagnosed, almost 300 to 195. They were randomized into the old-fashioned regimen Lendex. Remember that was the one approved and validated thanks to the so-called first randomized trial published in 2014 by Dr. Facon and colleagues, versus daratumumab lenalidomide, and of course, skipping dexamethasone. So you can make significant improvement by just making subtle changes. It is randomized. These are the groups. They are balanced, including more than 60% of the patient were aged above 80. So it's an important piece of information. We're talking about a very old and relatively frail population. You can see upper limit up to 92. And this is the beautiful progression-free survival curves, clearly showing that we can skip actually dexamethasone by giving daratumumab lenalidomide versus lenalidomide dex. You can achieve a 50% improvement, and this is going to improve the overall survival of these patients. So it's not a cosmetic PFS advantage. It is a true overall survival advantage. And I believe this is going to be a practice-changing study in this population. And of course, I don't need to spend a lot of time to convince this audience about the side effects of dexamethasone, and every dexamethasone sparing strategy is very welcome. And here we could see it is effective, it is safe for those frail patients. The field of the elderly population is also moving in different directions, because we're talking about the continuous treatment, and the backbone today is about an anti-CD38 plus Lendex. Maybe tomorrow we'll have a bispecific antibody Frontline. But here I think Dr. Osmani and colleague presented a phase 1 study introducing actually an antibody drug conjugate, namely Belantamab, targeting BCMA. And this is the so-called DREAM9 interim analysis. This is a DREAM9 trial in this old population. And you can see it's a very busy, complicated slide, but the bottom line is that they used standard of care VRD. We know in many parts of the world, VRD is widely used in this population, bortezomib, lenalidomide, dexamethasone. And they have added to the standard of care Belantamab, different dosage, different schedule. I won't have time to go into all of these details. The overall median age was 74. So this is truly in line with the patient we see in real world. These are the characteristics, and the authors should be praised because they have also paid attention to ethnicity, diversity, inclusion. And I think it is feasible. Of course, there is this issue of keratitis and ocular events, but it looks like that by reducing the dosage, by reducing the frequency of administration, you may end up with a better tolerance. Only 15% had grade 3-4 events. And you can see here the distribution. The interpretation is a little bit complicated because we are in a phase 1 study, because starting with higher doses is going to induce deeper efficacy, but then reducing and decreasing the frequency is likely a good option for these patients. So this study, and I'll show you another study in the relapse setting, I think Belantamab is definitely strongly back to business. It has been resuscitated, and that's really a very, very good news to the myeloma field. CAR-T cells, relapse refractory setting and CAR-T cells. I think one highlight that was, I think, discussed and praised by everybody, you all well aware that we have today 2 constructs commercially available and approved, namely ide-cel and cilta-cel, both of them targeting BCMA. Well, we have today a new kid on the block, namely this novel D-domain binder construct called Anito-cel. So I will not go through all of these details, but I think this new construct may allow better tumor cell killing without prolonged inflammation, because the small d domain can facilitate the high transduction efficacy and CAR positivity, and then you can use a lower total cell dose, and this D-domain binder has a fast off rate and high CAR surface expression. Phase 2 study, so-called Imagine-1 study. These are patients who received prior IMiD, proteasome inhibitors, anti-CD38. The classical design, you need leukapheresis, bridging therapy if needed, then lymphodepletion with the classical fludarabine cyclophosphamide, and then infusion of 115 million CAR-T cells. These are the characteristics of the population, the safety cohort, the efficacy cohort. What I would like to emphasize, 16%, 15% had extramedullary disease, 86, 87% were triple refractory, 42% penta-refractory, and the median lines of therapies was 4. Remember, approval of ide-cel and cilta-cel was 6 lines of therapy, so slightly less advanced population, but on the other hand, more extramedullary disease, more high-risk cytogenetics, and despite all of these bad features, 97% response rate, and the majority are actually stringent CR and CR, more than 80%, more than VGPR. So very impressive efficacy, very quick. Time to first response is 1 month, and the median time to MRD negativity is also 1 month. So really, if they have to respond, they will respond immediately. So this is ongoing. There is a randomized trial being planned or has started maybe, but clearly this is a very new and most welcome construct, because this Anito-cel construct can induce deep, durable responses in those heavily pretreated patients. And so far, although the follow-up is relatively short, we didn't see long-term or delayed side effects like Parkinsonism or MNTs. So time will tell, but this is really great news. As I mentioned, we have ide-cel and cilta-cel being approved, and of course, you may wish to compare them. And of course, there's no randomized or head-to-head comparison, but our friend Dr. Doris Hansen from the US, who has published some very nice real-world evidence data, managed to perform a multi-center retrospective study population. This is a flow diagram. I will not go into all of the details, but at the end of the day, they managed to compare 350 patients with ide-cel and 236 patients who received cilta-cel. As you may guess, by definition, this is not randomized, so there were some significant differences when it comes to performance status, to the lymphodepleting strategy, to the ferritin level at baseline, which can reflect the inflammatory process, but also the bridging therapy. And to make a long story short, and this is something people were suspecting, that the non-relapse mortality was slightly higher when you receive cilta-cel. So you have a greater efficacy with cilta-cel, but maybe you have more toxicity, although this was not statistically significant. So the blue curve here, the cumulative incidence of non-relapse mortality. But this is actually countered by a better efficacy, whether you consider PFS or progression-free survival or overall survival. Clearly, in the intention to treat, in the infused cohort, the results are in favor of cilta-cel. So really, very good news, quite reassuring for the community. And I think both constructs are available. Then, depending on the profile of the patient, we may wish to go into one or another of these constructs. One key issue we are facing in the field of CAR T cells for relapse myeloma is a bridging issue because it still takes time, several weeks, to get these CAR-T cells manufactured. And we are always facing the problem, what can I do while waiting for my CAR-T cells, especially in those patients who have an aggressive relapse and they need therapy immediately. So bridging is a sort of a billion-dollar question. And of course, these are refractory patients. So you may think, what kind of bridging I'm going to do? And here we have Dr. Binod Dakal and colleagues actually managed to do a real-world analysis from the US where they found a nice cohort receiving Talquetamab bridging, a bispecific antibody targeting GPRC5D for bridging. Again, you can see the study design. It is retrospective, but at the end of the day, the median follow-up is relatively short, but we have 65 patients who were infused with CAR-T cells, and they have received prior Talquetamab as bridging. You can appreciate here that half of the patients have really improved the response between Talquetamab to CAR-T cells. So very effective bridging strategy with relatively good safety. Because, as we all know, when you use Talquetamab continuous therapy for relapse refractory, we are facing some skin, nail, oral toxicities, dysgeusia, mucositis, weight loss because loss of appetite. We do see these side effects. They are highlighted in red here, but actually no grades 3 and 4, 1 or 2 cases. So it means they are probably temporary, and most of them, they will recover. So really good news, and although this is not the label, but it may be a smart, very nice way of using bispecific antibodies, especially Talquetamab, to bridge to CAR-T cells, because in general, we try whenever possible to favor CAR-T cells. And when it comes to targeting GPRC5D, I thought to highlight this study with a new CAR-T cell construct targeting GPRC5D, actually. And this was presented by Dr. Susan Ball and colleagues. And you can see the schema, leukapheresis, relapse refractory patient, more than 3 lines of therapies, including transplant, lymphodepletion as usual, and then this famous Arlo-cel infusion directed against GPRC5D. Just to highlight the characteristics of the population, 35 to 46% had extramedullary disease, 5 lines of prior therapies, including almost half of the patient received prior anti-BCMA therapy. So this is really a very advanced population. And as you may guess, today we're struggling with those patients who are progressing and relapsing, disease relapsing after anti-BCMA treatment. So we have some good news. CRS, ICANS, not really a big matter of concerns. Incidence is quite high of CRS, but very few grades 3 and 4. We do have, so when you use CAR-T cells against GPRC5D, you do not abrogate skin, nail, or oral toxicity. They do exist. Probably the incidence is lower, and the majority are going to recover. The other interesting information is that there are no reports of Parkinsonism or cranial nerve palsy or Guillain-Barré syndrome. Another good news, 50% are going to reach CR, including stringent CR, and the median duration of response is 18 months. Remember, a big number of these patients, a significant proportion, failed anti-BCMA therapy. Despite this, you achieve 18 months. So Arlo-cel is really an excellent option. And I think for those patients who are progressing after receiving anti-BCMA therapy, this new construct is going to bring some good solutions. Let's move now to antibody-drug conjugate. And I already mentioned that Belantamab targeting BCMA as an antibody-drug conjugate is likely now back strongly into the field. And when you consider the relapse refractory setting, earlier lines of relapse, one major highlight which was really praised and discussed positively by the majority of the investigators was about the updates, the survival, the overall survival analysis and updated efficacy outcome of the so-called DREAM-7 trial. The trial was published already in the New England Journal of Medicine, and this is a trial in those patients who relapse after at least one prior line of therapy. They did not receive any prior treatment with anti-BCMA, and it's a very straightforward one-to-one randomization. Dara-vel-dex, daratumumab, bortezomib, dexamethasone, like in the CASTOR trial, you may remember the CASTOR trial from 10 years ago, versus Belantamab, bortezomib, dexamethasone. Very nice way having like almost head-to-head comparison of anti-BCMA versus anti-CD38, Belantamab versus daratumumab. The populations, it's phase 3, randomized. The populations were balanced. You can see here the characteristic. For the sake of time, I'll go immediately to the key highlight. And actually, the use of BVD, Belantamab, bortezomib, dexamethasone, had an early, sustained, and statistically significant overall survival benefit when compared to the Dara-vel-dex. And this is a 42% improvement. And we're talking about overall survival. Remember, in myeloma, we are always struggling with the fact that it's very difficult to find an overall survival advantage because patients are going to receive multiple lines of treatment and you can always salvage them. And here you have an overall survival advantage, which means that the regimen is very strong, very well tolerated, but also the regimen is not inducing resistance. And this is also true and quite convincing because at time of relapse, the control arm, the patient received daratumumab after BVD, while carfilzomib was often given after DVD. So the patient in the subsequent therapies received relatively state-of-the-art treatment. Now, what about the side effect? The ocular adverse events are well known, well documented when it comes to using Belantamab. In this updated follow-up, there's nothing, I would say, new compared to the primary analysis. You can see the description of the blurred vision, dry eyes, photophobia, irritation, foreign body sensation, pain, of course. But it looks like, again, and this is something I think we will debate in the near future in the different roundtables that the ICH will organize, clearly by giving longer cycles of Belantamab-based combinations, we are likely will be able to circumvent these side effects. So clearly, this regimen, in my opinion, is here to stay, and we're looking forward to the approval of Belantamab VD. Of course, everybody's waiting for the bispecific because I mentioned bispecific in induction, transplant-eligible, in maintenance, but the bispecifics in the relapse refractory setting are making their way. We have 3 bispecifics already approved. I already mentioned Talquetamab against GPRC5D, but we have against BCMA 2 bispecific, elranatamab and Teclistamab. So elranatamab, we had data from the phase 1b magnetism MM20 trial. And this is an interesting study presented by Dr. Thomason and colleagues, because usually, and the drugs, the bispecifics are approved as single agent, but here they were combined, and this is now the era of combinations with carfilzomib. You can see the design here, dosing schedule. Of course, we are in a phase 1. We have the step-up dosing of elranatamab as usual, and carfilzomib has been used 70 milligram per square meter. This is the usual once weekly. The populations are summarized here, small numbers, 12 patients. But again, I think it's a nice proof of concept in this population that we can combine a proteasome inhibitor with an anti-BCMA bispecific antibody. And actually, the response rate is 100% overall response rate, and the median time to response was very, very quick. So I like this proof of concept. In the bispecific antibodies, we have also some good news from Cevostamab. So another bispecific antibody targeting now another tumor antigen called FCRH5. Dr. Josh Richter from New York made a fantastic presentation about the phase 1 study testing Cevostamab. Again, I will not go into the details of the different cohorts from this study, but you can appreciate these are heavily pretreated patients, number of lines of prior therapy, 6 up to 18, majority triple class refractory, and even 70 to 85% were penta-drug refractory. But most importantly, up to 70% have received an anti-BCMA targeted therapy. And this is, again, the unmet medical need to all of us. And despite this, well, first of all, this Cevostamab at the 160 milligram TD level and a decent cohort, 167 patient, was very well tolerated. We have a few cytopenias. CRS are mainly grade 1 and 2, thanks to the step-up dosing. And when it comes to infection, the majority were grade 1 and 2. So the story is here, the scenario is different from the anti-BCMA, because of course, when you target BCMA, you are also killing the normal plasma cells, and you are, of course, abrogating the secretion of immunoglobulins. The story may be different when you target FCRH5. So mainly a grade 1 and 2 infections. So really, and you can see the activity is really highly active Cevostamab in patient with heavily pretreated and refractory disease. And you can see the distribution, whether you have received CAR-T cells, no CAR-T cells, antibody drug conjugate, prior bispecific. At the end of the day, I think it's an excellent efficacy profile. And we're talking in those patients more than VGPR, 21 months of median duration of response. So all of this is really reassuring, and we are eagerly waiting to have access to Cevostamab, because obviously more and more patients are waiting after anti-BCMA therapies. Another big highlight that was presented by Dr. Hank Quash, the first results of a tri-specific antibody. So not bispecific. Now we're targeting both BCMA and CD38 on the plasma cell and CD3 on the lymphocyte in relapse refractory multiple myeloma. This is the structure of this tri-specific. Again, we are in phase 1, only 20 patients. You can see 30% extramedullary disease, 45% received actually bispecific antibodies. And you can see all the characteristics, including they have received anti-FCRH5, anti-GPRC5D. Very good news. 15%, 3 patients had a grade 3 infection. So that is extremely promising. And when it comes to the efficacy, again, it looks like these tri-specific antibodies are really doing very well. And if you focus on those patients receiving prior CAR-T cells, prior bispecific, again, the results are quite convincing. And of course, the study is ongoing, but my best guess is that tri-specific will make it very quickly. I wanted also to highlight some small molecules, and of course, we all know the IMiDs, thalidomide, lenalidomide, pomalidomide, but now the excitement is also about the new cell modes, namely iberdomide and mezigdomide. And I thought to show you this update from the MM02 trial with mezigdomide plus dexamethasone and combined with proteasome inhibitors, because I think this is of great value to many patients who are in relapse. Again, different cohorts and combining mezigdomide plus bortezomib dex, cohort A. Then you have cohort C, mezigdomide, carfilzomib dex. We have another one with daratumumab, another one with elotuzumab, but the focus today is about bortezomib and carfilzomib. And again, I want to go into the details. These are pre-treated, relapse refractory patient. They received all kind of treatment, but we do have a very nice swimmer plot for responders with dose escalation. Clearly, using these small molecules, first of all, they can be nicely combined with proteasome inhibitors. The other good news is that the safety profile, at least from my perspective, is quite good because it's about neutropenia. We are hematologists, we're used to this, that can be managed with GCSF treatment and very few grade 3 to 4 infection. Of course, it's difficult to draw conclusions from this PFS curve, but I think these are very good, convincing results that further reassure us about the value of this new family of cell modes, namely Mezigdomide, but hopefully also Iberdomide, and there are now randomized trials, and hopefully we'll get more results. So in summary, and I'll try to stick to my 46, 47 minutes. If I have to give you takeaways, well, of course, treatment of high-risk smoldering myeloma is around the corner now with the AQUILA results. I think we have to acknowledge that the bispecific, namely the anti-BCMA, are making their way into induction and maintenance. Remember Majestic 4, Majestic 5 studies in the frontline setting. But now there is more and more focus on targeting other antigens like GPRC5D, Teclistamab, but also CAR-T cells against GPRC5D, Cevostamab against FcRH5. And for CAR-T cells, beside modifying the antigen, you can have a new construct, Anito-cel, Arlo-cel. Trispecifics are likely to be the next generation of antibodies, and I already alluded to the fact that the antibody drug conjugate Belantamab has been, in my opinion, resuscitated. So these are really very, very good news, and I hope I managed to convey to you the spirit of all of these lovely updates from ASH. It was a very, very rich ASH meeting as usual, and I think we will remember this ASH in the next few years. So we have a lot of questions. One question here, DREAM7, based on DREAM7, can it be said that BCMA is a more important molecule for the treatment of myeloma than CD38? Maybe yes, it's a head-to-head comparison, but of course, please don't misunderstand me. We should not minimize the role of anti-CD38 because remember, daratumumab and cetuximab has represented a huge advance in the life of many patients. So we have a question from Dr. Kaveh Sami, whether Belantamab could be used as bridging for CAR-T cells. The short answer, yes, it has been used. And of course, the question is, because you're targeting the same antigen as the CAR-T cells, I'm not aware of controlled data for this, but definitely it has been done. We have a question about whether there are a change in the treatment algorithm today of multiple myeloma after ASH 2024. I think when it comes to the frontline setting, we have consolidation of the current algorithm using quadruplet induction dara-VRd, for instance, auto-transplant and maintenance. In the elderly population, yes, there are changes. We can skip dexamethasone thanks to the IFM 2017 trial. But also in the older population, we can also in those old and fit patients actually use quadruplet, and this is the IMROSE trial, ESA-VRd, the Cepheus trial, dara-VRd. I didn't discuss them because there were no updates, but you heard from the German studies about the consolidation of the data of ESA-VRd. we have a question. So I'm reading the question, trying to mix some questions because otherwise we can spend the whole night in the evening on these questions. So do we have new data reports regarding secondary tumors after CAR T cells? I didn't hear any new information about this. And I guess this is, you're alluding in this question to the risk of T-cell lymphoma that was discussed several months ago, but I didn't see more data at this ASH meeting. So we have a question in view of all of these results. Do you think in our lifetime that auto transplant will be obsolete? Yes and no, because no treatment is going to be obsolete. We will always need all treatments until we treat, until we can cure all these patients. So for me, it's not the debate transplant versus no transplant. It's more about how can I optimize the treatment of a given patient to improve the probability of cure. Another question about the elderly population. Should we include anti-CD38 monoclonal antibodies in the frontline setting? My short answer is yes. I think the data are quite convincing. One question here from Dr. Salihoglu. How do we do MRD assessment? Well, it can be NGF, NGS. I think I didn't discuss this. Smoldering myeloma, is this going to be practice changing the AQUILA trial? I don't know yet. I think it's very fresh. We need to dig a little bit more into the data, but I think it is probably the most convincing and strong piece of information we have in the relapse refractory setting. Of course, we have Dr. Gyang Lu asking me, what is the ideal sequencing between anti-BCMA, anti-GPRC5D, anti-FCRH5? Well, I wish I knew the answer, Dr. Lu, but this is like, it will take us several hours to discuss this. But my feeling is I always prefer to use CAR T cells. I prefer to target first BCMA and then the other targets. So I think because we're running out of time and actually there are other ICH activities planned in a few minutes. So I will stop here. I would like to thank you all for following this webinar. I hope you have enjoyed it. I hope I managed to convey to you the most recent data. And for the time being, again, Happy New Year, best wishes, and hope to catch up with you very soon in another ICH activity. Thank you and take care.